Hi, and welcome to BeautyCurious. My name is Dr. Elyse Love, and I am a board-certified dermatologist.
And I'm Ian Michael Crumm, a licensed esthetician.
Ian and I are excited to become your trusted beauty guides, from interviews with the best and brightest names in the industry to sharing our favorite expert-approved products.
We are here to help you navigate the noise by giving you the facts. Are you feeling beauty curious? Let's dive into today's episode.
Hello, everyone. Welcome back to BeautyCurious. I am super excited about this episode. We have Dr. Finney on the podcast. Hair loss is so common, and so there's so many myths and misunderstandings about hair loss. And so we'll kind of get into how you can actually know if you're losing your hair, or sometimes it is just nice for like peace of mind to be proactive and go in and get measurements and see someone like yourself.
Definitely. Well, thank you. And thank you both for inviting me on here. I'm excited to be a part of this. I loved all of your other episodes. Originally from Pittsburgh, Pennsylvania, so kind of a Midwesterner. Luckily, I don't have a terrible accent there, but I did my training all in Pennsylvania for the most part, slowly migrating east for undergrad and medical school to Jefferson and Philadelphia for my dermatology training. And then I ended up in New York here to do an extra year fellowship for hair restoration and aesthetics. So that's where kind of my passion for hair began. And I've been practicing now in New York City for about 8 years. And just this past year, I opened up my own clinic here in West Soho, Hudson Square area called Soho Skin and Hair Restoration, where, as the name entails, a big part of the practice is hair restoration. So my passion really kind of lies in the nitty gritty and the science, and that all stemmed from selfish, not altruistic reasons, because I started thinning as a 24-year-old male and wanted to blame it on, the stress of medical school, but we'll get into the science later. So a lot of the treatments that I have here were tested out on this scalp.
And your new practice, I can attest, is really gorgeous. I have toured it. I feel like I have so many guy friends who ask me what to do with hair, and you've been my go-to referral. I thought my hairline might be thinning, and Dr. Finney thankfully documented my hairline so we can keep track in case it does start to thin.
You're one of the lucky
Yeah.
few. You
I
still
know.
got great hair,
Yeah.
so hopefully you can keep it. But if not, we'll help you out. But
Exactly.
it's looking great.
I love, that we're talking about the science, because everyone feels like they're losing their hair. And a lot of times they are. Sometimes it is just nice for like peace of mind to be proactive and go in and get measurements and see someone like yourself. The one thing I will say as like a caveat for this is that there are a lot of different types of hair loss, and we could not do justice to all of them within one episode. So we will mostly focus on something called androgenetic hair loss, which is a type of hair loss that affects both men and women. And so we'll talk about both male pattern hair loss and female pattern hair loss, but I will just like throw it to you. How do you explain this type of hair loss?
Yeah, so I mean, statistically speaking, by far and away the most common type of hair loss. And as you alluded to, there are various different types, including some that can be prevented from a medical standpoint. So it's always important for anybody who thinks they're suffering to get in and see somebody who specializes in hair, just so that you can get evaluated and make sure that you're not inappropriately finding your way to treatments that are available over the counter or via some of these subscription services that aren't able to analyze your scalp. But, the way to describe androgenetic alopecia, it's tough. You have to debunk some stuff. Well, my mom or my dad or my mom's dad's dad or, my dad's mom's mom, there's no hair loss. And although we call it genetic hair loss, it's polygenetic, right? And so first, when I'm trying to explain that, it's more, if you think long and hard enough about it, you'll think of a set of brothers or a set of sisters with completely different heads of hair. We know that there is a genetic preponderance and genetics plays the role, but you cannot trace it back. So I don't care about the family tree of hair. Now, that being said, if you have a strong family history of a lot of bald people, you're going to be at higher risk, as with anything. But the way to explain this condition that I found, essentially, that if you are predisposed, it's a spectrum. You might be predisposed to start thinning earlier, later, but whenever that happens, a switch flips in you, and all of a sudden, hairs in a certain pattern on your scalp are starting to become sensitive to androgens that are circulating in everyone, notably an androgen called dihydrotestosterone. And what that does is it's going to attack the hairs that are susceptible, causing them to become weaker and more miniaturized. And instead of growing long and strong, and if you wanted to grow your hair out to here, you could, when it starts to become weakened and miniaturized, it's not going to be able to grow as long. It's going to break easier. It might not withstand the heat and the different treatments that you used to do. And that pattern continues until all of a sudden, poof, that follicle goes on a disappearing axis. When you examine a person, if you see signs of miniaturization, the only thing that really does that is genetics. And if you can see that on exam, it's easy to say we can put all this other stuff on the side, like stress and vitamins and whatnot.
Is there a difference between female and male? Because I've heard a lot of people, say male pattern baldness. So how does it differ between male and female?
So there are still things that need to be more clearly elucidated for female pattern hair loss. I lump them all in the same, that they're androgen driven, that switch flips and your hairs become sensitive to androgens. That being said, when you hear dihydrotestosterone or testosterone, it's not causing it, right? If you have high levels of testosterone, yet you are not genetically predisposed, you won't thin, right? And I think the best example is men taking steroids. If you are susceptible, it will ramp up your hair loss. It will thin quicker. I think the analogous in females, when androgens are elevated for like something like polycystic ovarian syndrome, if you're predisposed, it will make it worse. If you look in the science, there are papers that will talk about estrogen levels, androgen levels in the follicle of females who suffer from early hair loss. And in normoandrogenic patients, they have noted some differences in the different enzymes in the actual hair follicles. There's an enzyme called 5-alpha reductase that turns testosterone into dihydrotestosterone or DHT. And that being elevated in the follicle, again, can make more DHT locally, accelerate hair loss. They've found that another enzyme that would take testosterone and make it estrogen, if those levels are elevated, aromatase in the follicles, that there's kind of a protective effect. So although a lot of people will say it's not clearly elucidated, they're really saying that because sometimes female pattern hair loss doesn't respond as well as males to DHT blockers specifically. I do think that the root cause is still very similar, if not the same, but we just don't have the full science to back it yet.
I oversimplify it, but basically I tell patients that almost everyone will be affected by this. Like, there are studies that show that like 80 to 90% of people will develop male or female pattern hair loss at some point. But what we know is that some people may not start to develop thinning until their 60s or 70s, whereas other people are going to start to notice it in their 20s and 30s. And so there's a different age of onset for different people, and everyone has a different natural history. How do you talk to people when they say like, okay, if I don't do any type of treatment, what's going to happen?
I think the easiest high level way to describe it is the earlier you start thinning, typically the more aggressive it's going to be. If you come in and you're a male and you're in your teenage years still, and you have signs of miniaturization already, if we don't do some oral medications and office treatments, we're not going to be successful. Whereas if you started thinning 10 years later, 20 years later, the later it hits you, the less aggressive it tends to be. I think that if you start thinning in your teens, you're going to go bald, if you're a male. If you don't, again, really do a lot to intervene. If you start thinning in your 40s as a male, it's a different story, right? You're still going to, have hair in your 70s, 80s, but just not as much. So with women, it's a little bit different because it's not as noticeable, right? As you say, most people will suffer from it, over 50% of women at some point. But really, in reality, not a lot of people know if a woman is thinning. They will know themselves because one of the first signs is they put on a ponytail and it's not as thick as it used to be. There's a very slow, subtle thread across the crown of the scalp or the top of the scalp along the part, and that's when you'll see some start to part differently or along the frontal hairline. And again, it's still related to at what age did you notice this? Unfortunately, I have some younger women in their early 20s and they're destined to be thinner. Luckily, still not bald like men, but it will get much more noticeable. So I think it's really age of onset determines, how aggressive it's going to be.
Yeah, that's so useful. It's so funny because a lot of times when I ask female patients, I say like, is there any history of hair loss? They always say, or many of them will say, oh, well, my mom, but she's always had thin hair. And then I'm always like, has she always had thin hair, or has she had thin hair since you've known her? And they're like always blown away by that idea that their mother had like a life and like a whole like head of hair before they knew them. So that's always like an important thing where sometimes people don't think about the fact that your parents you've only known them in their adult life. So a
Exactly.
lot of times you have to ask the question of, has the density of your hair changed over time?
When somebody is very early stages, maybe they had an increase in shed, and we'll talk about, that cause
Yeah.
of hair loss, and it's a little distressing. It's easy for one of us to take good photos and then say, hey, do nothing. Let's see you back in 6 months. If we're
Yeah.
following up on it regularly. You don't have to look in the mirror every day and wonder how many strands are coming out. Let us take that stress from you, and let's just check back in. And if we see early signs, we'll intervene early, and we're very successful.
That's so important because hair loss and hair growth is so slow that sometimes people
Yep.
really feel like they're going crazy because they're like, I feel like I'm thinning. I don't know if I'm thinning. And so, exactly what you said, a lot of times what happens is that people, they're like, you know, do I have less hair? Do I not have less hair? And then at some point they put their hair in a ponytail and they're like, this is different. This is less hair than I had before. Or like my part looks different. But yeah, if you have a question, especially if you live in New York City, then you should come in and
Come
see
on
Dr.
over.
Finney. Yeah.
The mention of stress I thought was interesting. So what's the difference between
Yeah.
androgenetic hair loss and stress-induced hair loss? I also feel like we're thankfully out of the pandemic, but during the pandemic, so many people were talking about their hair and thinking they were losing it. Did that play a
Yeah.
part in stress-induced hair loss, and what are those differences?
Most commonly, we see genetic hair loss, but the other big cause of hair loss is telogen effluvium, which stress-induced hair loss falls under. Post-viral induced hair loss like COVID, which there were a lot of people that had an increase in shedding from that. Medication-induced medical illness, loss of a
Postpartum.
family member. Yeah, postpartum is a huge one. If you had a hospital stay and you were sick or surgery, all those things fall under that telogen effluvium kind of group of people. You can have both, right? And I think that the easy way to explain it is I always ask the question, how has your shedding been? And you can get varying answers to that because when you're suffering from hair loss and you are thinning, you start to count hairs and you start to think normal is actually abnormal. But has there been a period where you were going like this and then all of a sudden your shedding picked up significantly, like it was at least twice or, 1.5 times? And, did that period stop and come back down to normal, or has it continued? And with stress-induced or any telogen effluvium, all of a sudden over your scalp, it doesn't care where the hair is, they just start to go into the resting phase, right? So you're going to see an abrupt increase in hair fall. With genetic hair loss, that's going to be slow. It's kind of like a smoldering thing where over time your part slowly starts to widen, or your hairline's going back, or you're getting smoother back here. It's not acute, right? It doesn't happen acutely. You can have both. And I think what we saw during the pandemic was COVID had a post-viral shed in a lot of people, and that unmasked the genetic component of things earlier, because normally those stress-induced telogen effluviums, they all regrow. The hair loss will stop and it'll all regrow. It's not scarring. But if you have a preponderance for genetic hair loss, maybe only 80% of it regrew. So, the shedding might have come down for them, but their ponytail doesn't feel like it used to, or their hairline doesn't look quite as strong as it used to. If I have a patient that had an acute episode of shedding, we talk about, hey, do we need to check your thyroid? Do we need to check your iron? Do we need to check different labs that might be contributing to ongoing shedding? Also, seasonal shedding and other things. Right now, I think that analogous to hair, similar to what happened during COVID, is Ozempic, right?
Yeah.
That's causing hair loss because people
Yeah.
aren't consuming enough protein or calories, and your hair needs that. So yeah, that's kind of how I lump the two together.
For someone who's having a telogen effluvium or like an acute stress shedding, do you do anything or do you do reassurance?
I do reassurance, and then I
Yeah.
offer them treatment options. The two that I usually talk about the most, minoxidil topically is what I prefer, but annoyingly, that has an increase in shed at first. So that's a hard sell, but I do tell them that it will help the regrowth quicker. So that the only thing that I've seen stop significant telogen acutely has been platelet-rich plasma shots. I've tried
Yeah.
other growth factor-based treatments. It doesn't always work after one, but usually 1 to 2 treatments will significantly reduce the shedding, back below a normal level, and then after several weeks get back to a normal level. But if they're very motivated and they have the funds, then it's a great treatment that can really stop an acute shed.
So with acute shedding or with stress-induced shedding, it's almost always short term, but I feel like if you work in like tech startups in New York City, sometimes you can get something rare called a chronic telogen effluvium, where you're just like chronically shedding. And I have found that PRP is like very helpful for that.
I'm just I'm learning so much. I'm soaking it all in. I can't wait to re-listen to this conversation when we publish. I'm curious. I feel like this is a very massive topic, and there, as you're mentioning, with beyond androgenetic, there's a lot of different, ways that someone can lose hair and things to consider. I know we're gonna dive into a lot of treatment options soon, but before we do that, what are like the biggest myths and misconceptions that you hear either on social or in your practice about people and what they think is going on with their hair?
I think one of the biggest misconceptions, or not misconceptions, is more a hurdle to therapy. They're scared to start treatment because they're like, well, if I stop it, then I'll lose the effect, right? And I went through that back when I was 24 too. It truly, it's a little bit daunting, especially at younger ages, committing to therapy for the rest of the life. So, one of the things that I always tell patients, I'm like, look in the mirror, right? If you value your hair, you will find a way to do these treatments. It's not going to make you worse off. That's the myth. People think if I start this and I stop it 5 years from now, I'll be worse off. No, it just delayed what was going to happen. And if you stop it at whatever point you do, you'll get back to the point on the curve that your genetic hair loss was going to land you in. So it's not going to make you worse. Just if you care about your hair, now is the time to intervene. If you wait 3 years and now come to the realization that, hey, I value my hair now and a lot more of it's gone, it's going to be a lot more expensive for you to try to get back the hair that you lost during that period of time. Once you start to do it, it gets a little bit less daunting. And for people who are younger, hair loss, even the treatments, has drastically changed in the past 8 years. We have so many options now that we did not have back then, and more things are coming out. So try not to be scared from it. I think another myth, well, I'm not washing my hair much now because I've heard that can contribute. And I think it's more just PTSD from if you know that you're thinning or see it. And then every time you wash your hair, comb your hair, do something, you see more strands fall. You want each one of those back on your scalp, right? For that, I always tell people, actually, that's a myth as well. If you do that, your scalp's not going to be in good health. It might, build up more dandruff. Your oil is going to clog your pores a little bit. It can create other problems. And they've actually done studies that show that if you practice better scalp care, you'll have less oxidative stress up there, less dandruff, less hair fall. And that's how, if you look at a bottle of Head and Shoulders, it tells you that it'll help with hair loss. And they actually did this study and proved the science that using zinc pyrithione is actually going to reduce your hair fall if you use it daily, right? There's another study that shows that even if you just rinse your hair with water daily, that it's going to help. And then lastly, we have another ingredient called ketoconazole that has a study to show that it can help with genetic hair loss as well. So that's a big myth. I tell people to wash their hair as regularly as they can, which is different for different people and different hair types. Other myths, biotin's probably a big one. We see a lot of biotin supplements and a lot of people coming in saying, well, do you need to check my biotin? And although biotin deficiency can happen, especially with a genetic defect, which you would have known, all your life, if you're eating a normal diet, you're likely not deficient in biotin. And similar to stress in this telogen effluvium, an easy way to tell is if you have a telogen where you have a shed and that's the cause of your hair loss, it doesn't care where your hair is, right? It's not patterned. Your hair will fall from here, from here, from here, body hair. When you have genetic hair loss, you're thinning over certain areas. For men, our temples are going to shoot back, our hairline shoots back, we get smooth up on the crown. Whereas with women, usually in the frontal hairline and then slowly over the top of the scalp with the part widening. So another kind of easy way to differentiate. And biotin would cause that shed from all over if you were deficient in it, not genetic hair loss. Yet a lot of these hair supplements have very, very high doses of biotin, like 10,000 times the daily recommended value. And that's actually bad because if you have chest pain, you go to the hospital to check for a heart attack. It can throw off the lab values that they would check to see if your heart's dying. For thyroid, the excess biotin in the blood can actually bind the thyroid test and render it, off when maybe it's not. And thyroid, as we talked about earlier, can contribute to your hair being in a shedding phase. So that's another big myth that I wish would stop getting purported, and that they'd stop putting so much biotin in these supplements. Like, just put 100% of your daily value. That'd be fine.
10,000 times is a big number. Wait, so the mention about shampooing, I have to ask, how often do you shampoo your hair?
Daily. I have short hair,
me too. And even when I have short hair, I've had like other people like, oh, you don't have to wash it every day. And I'm like, no, I'm washing my hair every day. Like, I want to wash it.
Well, it's like, some people, I sweat when I sleep, right? So if I didn't shower in the morning, I don't think any patient would want to be near me. But some people can get away with that. They sweat less, they have less oil on their skin. Are there some people that don't need to wash their hair daily? Absolutely. In textured hair, if you do that, your hair is just going to break, right? Like it's going to damage the hair shaft, and it's just impossible to style it. You have longer hairstyles, same thing. Like who's going to get up an hour earlier to do their hair every day? So it doesn't need to be daily, but daily can help with hair fall. So
I think most people are underwashing their hair. It's like become
Yeah.
like the new trend. But one of
Yeah.
my favorite hair hacks is that Elyse, our RPA, she works out twice a day, twice a week because she wants to wash her hair less. I was like, I would have never thought about that. She's like, yeah, I work out twice a day and I wash my hair afterwards.
That's
Yeah,
wild.
I know.
So interesting.
That's self-awareness, right? Like I don't want my scalp smelling.
I never heard that one.
I know. I
Yeah.
never heard either. And I was like, that is among one of the smartest things I've heard. All right. So let's get into how to treat hair loss, because a lot of people are very overwhelmed. They're very confused. And we will definitely say that this obviously is not a replacement for talking to your dermatologist, but there are a lot of options. And sometimes it can be
Yep.
completely overwhelming to go in and hear all these options for the first time. And so really what I hope that this podcast can do is make people aware of the different types of treatment options, so that then when they come in and have this conversation with their dermatologist, that they just feel a little bit more empowered and they feel like they can make a decision a little bit quicker, versus you come in, you hear about all these things, and then you have to go home and Google everything. So we're just going to simplify it for you.
For sure. And I think for me in clinic, I try not to bombard them with, 7 or 8 options.
Yeah.
If they asked about other treatments that are available that they've heard of, then I'll talk about them. But I try to focus the conversation on, I want you to have a cornerstone of your therapy, whether that's topical or oral, that you do at home on a consistent basis. And that's going to be different for different patients. Again, as we talked about, different stages of hair loss. If you've caught it early, preventative is going to be easier. If you caught it late and we really want to maximize regrowth, that will adjust the way that I tell you you're going to have the highest chance for success, whether that's pills or topicals or the number of each. But a cornerstone of therapy should include ingredients that ideally stabilize, so blocking an androgen, as well as, if you can, regrow hair, because the ingredients that block DHT aren't always the best at regrowth, but they're very important for long-term stabilization, especially in our male patients. If you're a male and you're suffering from genetic hair loss and you don't have a DHT blocker, you will lose the battle, hands down. And whether that's topical, oral, in-office treatment, you need one, right? So we always pick a DHT blocker. And I ask them, hey, do you want orals or topicals then, is the next question. For my female pattern hair loss, it's been an issue. I had a really nice, elegant DHT blocker that no cosmetic chemist can source right now for the past 6 months. But the alternative to that is a little bit smelly, called spironolactone. But again, similar question and similar routine. Do you want topical or do you want oral? I'm going to talk to you about minoxidil and a DHT blocker. In men, it's going to be finasteride, dutasteride. Also have that same conversation in peri or postmenopausal women. In premenopausal women, it's still minoxidil, and it's usually spironolactone or a breakdown product. So, having a cornerstone of your therapy, whether that's a topical that you do daily or orals that you take at home. And then the things that we do in office are typically adjunctive. I get a lot of patients that come in that were offered in-office treatments that are growth factor based, like PRP, and that was their sole therapy, and they're coming into me because it wasn't working. And it sucks because it gives these treatments a bad name, and they really do work, but their place is adjunctive. I talk about the cornerstone therapy being pills or topicals, and then I talk about, hey, if your goal is to regrow hair, you're only going to be happy if we get more hair for you back on your scalp and not just maybe a little boost in stabilization. We have to talk about adding in growth factors to that. They do have topical over-the-counter forms. There are more that we can do in office, whether injectable or microneedled, or using devices such as laser or ultrasound to deliver. But really picking a cornerstone, including a DHT blocker and something to help regrow hair like minoxidil, and then do they need in-office treatments? My biggest passion has been to try to get treatment option that was in office, that was all in one, including a DHT blocker and growth factors all in one, so that you can not only stabilize your hair long term and hold on to it with not the side effects of the orals, but also regrow hair. And so my passion over the past 3 years has been doing that. And it can work as a standalone therapy for people who don't want to put topicals on or don't want to take pills and suffer from side effects. But I think they need to focus on the ingredients. And I don't talk about low-level laser light, rosemary oil, any kind of hair vitamin like Nutrafol or Viviscal or Vegamore, at-home microneedling. I'm not bringing up those conversations because it's even a lot. Like it took me 5 minutes to say right there, right? I want them to focus on the things that are going to work the best. And those tried and true ingredients are going to do that. And these other things, now, if they say no to both of those, then we start to get into tertiary treatments that they're going to have less evidence behind them. They're not going to be as successful, but everybody has to make a choice with themselves and what they're comfortable doing and putting in their body or on their body long term. As a clinician, we're here to give them the options and empower them to make the right choice that fits for their lifestyle.
And I'm curious, when you talk about minoxidil, obviously we can do that topically, we can do that orally. What are your feelings for, like, are you going for just the over-the-counter, like 5% minoxidil, or are you going for some of these like compounded higher percentages?
This is a podcast, we're not Uber, but I'm still going to ask you to give us a 5-star review after listening today. Thank you.
Yeah, so it depends. For my males that come in, I start the conversation on DHT because we need a DHT blocker. So
Yeah.
if pills are an option and they want to do pills, then it's more of minoxidil they're only going to get if they really need regrowth. And then I talk about it topically or orally. And in the event that they're taking an oral DHT blocker, I just tell them to use 5% over-the-counter Rogaine foam from minoxidil, 5% foam from Kirkland or Costco. That's the one that I use. But if they want topicals, then that's when I'll use the compounded version.
Okay.
Because if it's a topical solution, I will mix all of those ingredients into one so that you do not have to do multiple things. And same thing, for my female patients, it's, if we're doing topical and pre-Canrenone running out and having to use Spiro, I have the conversation of, how often do you get your hair wet? How often do you wash your hair? I have a bottle of the version with spironolactone in my office, and I let them smell it, and I say, listen,
Well, that's smart.
if this is okay, then we will send the compounded version. If it's not, then I want you to use minoxidil 5% over the counter. Don't pay the pink tax because they usually charge more for that. But yeah, just the over the counter version works well. And in female pattern hair loss, if you don't have that DHT blockade right away, you're not going to lose, right? You can still regrow hair. The androgen susceptibility is not as strong. So, until post-menopause hits and the estrogen plummets and there's no protective effect up there, then, we can give them the finasteride or dutasteride.
So is your most popular or preferred treatment prescribing a compound with the multiple ingredients versus having a couple steps for the patient?
Yeah, I say topical or oral. Orals are always going to be your strongest option, but you're going to have side effects. Personally, I had a decreased libido to finasteride. So for me, I was still taking it for a while because it was helping with my scalp, but ultimately, I'm 40 now, your libido goes down with time anyway. So I pivoted to topical in 2020 during COVID. And that was, again, I really wanted to get a stronger variant because my hair loss was pushing through a topical. So I say, if you have significant hair loss or you start thinning at an early age, I will recommend doing orals. And if you're doing orals, it's usually oral finasteride and oral minoxidil if you really need regrowth, because minoxidil is going to be the regrowth hero, whereas finasteride, dutasteride is really going to stabilize. So if you're open to orals, we start there. If you're not open to orals and you don't want to take them long term, then we do start with a topical. So it's really, hey, the efficacy of your orals are going to be here. Your topicals are going to be here. They may be enough. No matter what path we pick, I want to see you back in 6 months. If we don't hit the mark that we want, that's when we have to, hey, we could consider other things, switching to orals, adding in office treatments. But really, it's oral or topical, and then that kind of guidance.
And then what are your preferred in-office treatments? Like, what do you perform the most in your practice?
So at this point, I branded it as my Scalp Stim Pro treatments. It's a combination of the dutasteride and growth factors with a unique blend of growth factors and a unique delivery. And for all of my male patients, if they need regrowth, it's just been way better than the other growth factor-based treatments like platelet-rich plasma or Carolase or TED. And so I push them towards that. And if there's a premenopausal female that is not a good candidate for dutasteride, which most are not, if you're ever going to get pregnant, there's a risk. In theory, even though you're applying it and delivering it locally, you're going to get some systemic absorption. But if you were to get pregnant with a male fetus, it's not going to come out looking normal, and it's like a terrible side effect. So for them, it's usually having that conversation, and depending on their situation, more likely to do PRP in conjunction. Or I have a device here for needle phobic people called TED that uses ultrasound, so no needles, and a growth factor serum, and we can combine other things in there such as exosomes. So the biggest thing is, do they need a boost, and do they really need regrowth? If so, then we're having the conversation about you starting your orals or your topicals at home as your cornerstone of therapy, and then adding in our in-office treatment to maximize your chance for regrowth. And there was a study in men, one group who did topical minoxidil and the other who took oral finasteride. Half their scalps were injected with salt water for control, and then half with platelet-rich plasma. And the side that did the best was a little surprising in that it was the minoxidil topical plus the platelet-rich plasma shots. And it shows that there is synergy with the growth factors and the way that the minoxidil is able to help hair growth. So if you really need a treatment booster, or if you want to avoid the side effect of the oral or topical minoxidil where you have an increase in shed at first, you can do platelet-rich plasma at the same time to just kickstart into regrowth.
Okay, so walk me through, say, knock on wood, hopefully I don't have to deal with this, but say I'm dealing with more hair loss myself as a male. Walk me through your Scalp Stim Pro treatment. I'm in your office. What does that look like? Are you taking blood, like if someone was to get PRP, or what's happening?
No blood draw. Basically, I combine a sterile form of dutasteride, the strongest DHT blocker that we have, and a unique blend of growth factors, and into one topical solution. I apply that topically to your scalp and do a brief microneedling to create tiny little channels and drive both of those particles in. And then I have a lot more of the solution that I then apply per area of your scalp and use ultrasound to further drive it down the channels that I just created. So the upside is that we're very superficial in the scalp. We're just around the hair follicles. You're not seeing blood up there. So you know that if somebody, say, had a side effect from a DHT inhibitor like finasteride or dutasteride, the amount of systemic absorption in these treatments is going to be so low. Never in my practice, nor in the reported data, has anybody reported a sexual side effect. But you're bathing these follicles in a molecule that's going to protect it from DHT at the same time that you're delivering these powerful growth factors, that now that there's no DHT around to mess up with what they're doing, they're able to really regenerate the stem cells, thicken existing hairs that maybe were miniaturized, and regrow hairs that, maybe had gone for a little while. And I've been tinkering with the way to deliver it. Initially I had needles, and then I had needles and lasers, and then it took me 3.5 years to get to the current delivery system as well as ingredients. And in the past 7 months, what really impressed me was patients who were coming in and had been on, or were currently still on, topicals, orals, and with the history of, I failed a series of PRP that another provider did, or I tried some other growth factor based treatments, they did nothing, and or they were practically smooth bald and were regrowing hairs, where those are patients that before I had this to stand on, I wouldn't have sold them PRP, because if you're smooth bald, not much is going to do anything, even the topicals and the orals, because once a follicle leaves, you're not really reawakening it. And I even told that guy when I first treated him who was smooth that you might be throwing your money away. There's always a chance for no success with this. And to see the result that he got, this is a really powerful treatment. And that's why I don't do much PRP. I don't do much just TED. And really, I reserve those for premenopausal, or if somebody's suffering from an acute shed, that PRP would really help with.
And then what's the protocol for that treatment? How often are they getting it? And what's the maintenance? Because obviously there has to be some maintenance with all of these treatments.
Yeah, exactly. So no matter what treatment I do, if somebody needs regrowth, I usually do it once a month for 3 treatments, and then we judge it, right? So if it's something that we feel like added value, regrew your hair, then you're likely going to need a maintenance treatment once every 3 to 6 months. And the sliding scale is because what is your cornerstone of therapy at home? right?
Mhm.
If you're on oral medications, say like a really strong DHT blocker, and I regrow hair for you, in theory, your oral DHT blocker might hold on to that hair and protect it from, further effects of DHT. Whereas if you're doing nothing at home, you're going to need to come back every 3 months minimum. So it's a sliding scale. And usually I do that series and I judge it about 2 months afterwards and then tell them, listen, there's no exact playbook for this. We'll plan that you'll need to do a treatment at least every 6 months. If you feel like between, this follow-up and 6 months that the result that you got was slipping a little bit, hey, put the mark on the calendar, like it lasted this amount of time. But again, if you're on oral medications, maybe you don't see that and we check in at 6 months. And if you're still really happy, let's stretch it out. Let's check back in another 3 months. I think the biggest thing is just following up. We talked about it. You're committing to these things lifelong, right? I will say, some people who started thinning later in life are also usually more resistant to at-home treatments. The nice thing about this treatment is I have, many of my peri or postmenopausal women who are just coming in once a quarter or even stretching it out to once every 4 months and just doing the in-office treatment and have gotten a wow result, and then they're maintaining it without having to do the messy serums or the orals. Whereas myself personally, I still have the serum at home, right? And my goal is like, I'm not confident enough that my DHT blockade is going to be strong enough for 3 months that I can fully just break off of it. So I do push my male patients, especially if you started thinning at a younger age, like, hey, low hanging fruit, even if you had a side effect from orals and don't want to take pills, let me send you home with a topical. Even if you can get it on, somewhat frequently, it may increase the chance that you make it to 3, 4, 5, 6 months and just save yourself some money over the long term.
That's a good point. When it comes to kind of the topicals, do you feel like people need to use them every day, or does it just kind of depend on the intensity of and the speed of their hair loss?
Yeah, I think it does definitely depend on the speed of their hair loss. Younger people, topicals probably won't be enough. If you're a male or a woman in their 40s and they just started thinning, is it going to work every other day? Probably for a little bit. To me, it's tough to give somebody an inconsistent routine because I think that compliance fails if it's not part of your daily routine. And I always tell people, I say, I shower every day. My deodorant sits right next to my topicals for my hair loss. I don't leave the house without putting deodorant on. I don't leave the house without putting my hair loss treatment on. I don't know when you shower. I don't know what you do on a daily basis, but as part of your morning or night routine, I need to know if you have a consistent routine at either of those. And that's where we target. To me, I never tell people to use it infrequently. It's just when they're arguing with me about doing something at home, I'm like, listen, I make more money if you come back every 3 months and you sit in this chair and we do this treatment. But it's a marathon, right? Save yourself some money. If you don't care about it, come in, like we'll do the treatment. And, the longer hair patients, again, it's messy. And if you're not able to get your hair wet every day, it builds up and, it doesn't always look great. So I understand it, but that's where you really have to take into account somebody's lifestyle, what they're willing to do.
Speaking of that, if someone's not used to applying a topical every day, that's a lifestyle change, getting that as part of their routine. Yeah. Are there any other lifestyle changes you recommend that help with prevention or further loss?
Yeah. So, I try to give them less homework. I focus more on like, hey, your hair practice styles is not causing your genetic hair loss. That being said, you can set yourself up for success if you do certain things. I always just tell people like, hey, a hair that is miniaturized and damaged, at this point, if you could tie it in a tight ponytail or, put heavier extensions on or do whatever, now that's not going to withstand it, right? So if you can lessen the heat, if you can be gentle to your hair when you get out of the shower and it's wet, if you can wear looser hairstyles or lighter extensions if you're going to put them in, take breaks. If you're braiding it, take it out for, periods of time if you can. And then good scalp care, right? Because the follicle is growing underneath our skin. So we need to take care of the scalp skin because that's really where the issue is. And it's not the hair shaft outside of that. But there are a lot of other things that you can do that can damage that hair that is now fragile, and try to practice good hair care. But if I'm doing my job, hopefully I'm reversing some of the miniaturization so that maybe your hair can withstand some of the old practices. But because again, at the end of the day, I'm not going to tell somebody how to wear their hair, right? You have to wear your hair how you are comfortable wearing your hair. That's not my place to tell you. I will give you a guideline for, what's healthiest to keep it, in a good state. But ultimately, if you're choosing a certain hairstyle that might cause damage, then we're trying to come up with ways, creatively that still allow you to do that and keep your hair.
Potential complications, you mentioned hair extensions and trying to keep them out. It makes sense if someone is thinning and they're like, oh, let me add some hair extensions so I have a fuller look.
Yeah, I mean, again, once a hair is damaged already from genetics, it's going to withstand less. So you pile other things on, and it's going to potentially lead to other types of hair loss called traction alopecia, which tension, traction, weight. It can be, a vicious cycle because you're covering up one thing with something that's making it worse, right? So it really can accelerate things. If you can unclip them and not wear them while you're sleeping and only put them on when you need to, like, it's just going to be better for your follicles to give your hair a chance.
So I feel like that was an incredibly thorough review of why we're all losing our hair and how to treat it. I think one thing that's really important for people to understand is that hair regrows very slowly. How long do you tell patients to wait until you assess for growth?
Yeah, I always say, patients, I'm taking your photos. I want you to follow up every 6 months. You
Yeah.
want to come in a little sooner than that, depending on what we're doing. Again, if you're doing in-office growth factor treatments, you can see earlier results. And with the Scalp Stim Pro treatment, sometimes by the time they're sitting there for their 8-week follow-up at their third treatment, they're seeing a result. It takes 6 months before we judge things. So just be patient. And I can't tell you the number of times I have patients coming back at that 6-month mark, and they're like, Doc, I don't know if it's working. And when you're looking at your hair every day, it's tough to detect subtle change. And time again, they look much better today than they did back then. They just don't remember. So that's why it's tough to treat it at home. We have these objective standpoint or check-ins, and that way you don't have to stress about it because it is a very distressing condition. So be patient, follow up regularly. If you can't do that and you're trying an over-the-counter option, take good photos in the bathroom where there are no lights, close the door. That way you have repeatable lighting, and then just put them away. Hide them in your phone and set a reminder for 6 months. And don't peek at them until then.
Yeah.
And if you do, you lose faith. And that's why so many people come in and are like, these treatments didn't work. I tried them all. And then you ask how long, and it's just not enough. So patience.
100%
Patience
agree.
for the patients.
Exactly.
All right. Well, I actually really feel like I need to go wash my hair. Like I feel called out. So
Did not do that. Not everybody's able to.
thank you for having this conversation with us. But where can people kind of like follow you, keep in touch, keep learning from you?
Yeah, I mean, if you're in the New York City area, come to Hudson Square, West Soho to the practice. We can hang out here. Otherwise, I infrequently post on Instagram at Robert Finney, MD, and my practice is Soho Skin and Hair.
And we'll make sure that we put those in the show notes for everyone to be able to click.
All right, guys, thank you for your time and for your attention, and thank you for your expertise. And with that, I will say
Thank you,
goodbye.
Dr. Finney. Our DMs are always open.
We're always looking for new show ideas.
Ask us skincare questions.
Let us know what you're beauty curious about.
Give us a follow over
At our Instagram, at BeautyCuriousPod.
to see snippets from each show. Thanks for watching.